By the end of this lecture, you should be able to describe the general principles of managing sedation in ICU patients, explain the theoretical and practical aspects of feeding patients with critical illness, prescribe appropriate DVT prevention strategies, and understand the basic principles of stress ulcer prophylaxis. We're going to pause here for a minute. Why do you think it is important for ICU patients to receive enough sedation, but not too much sedation? Think about the question before we go on. The aims of sedation are to relieve anxiety, enhance tolerance of the endotracheal tube and mechanical ventilation, allow therapeutic and monitoring procedures, and control cerebral oxygen demand. Before discussing sedation further, it's important to address some common misconceptions. Firstly, pain should be treated with analgesia, not sedation. Similarly, if symptomatic treatment of delirium is required, the appropriate treatment is with an antipsychotic, not sedation. Finally, remember that while muscle relaxants will stop the patient moving, opening his or her eyes, and responding, they have no sedative properties, and if used alone, will result in a terrified patient who is awake but completely paralyzed. An important part of management of sedation is determining an appropriate level of sedation. This needs to be frequently reassessed. In general, lighter levels of sedation are preferable, but the appropriate level will depend on factors such as tolerance of the endotracheal tube if intubated, the need for invasive procedures, the difficulty of ventilation, and the presence of intracranial hypertension. When the patient is stable, the usual aim is to have a calm and alert or easily rousable patient. Contrary to expectations, continuous deep sedation is associated with greater longer-term psychological disturbance. Having decided an appropriate level of sedation, the drug should be titrated to achieve that level. This may be facilitated by use of a sedation score, such as the Richmond Agitation and Sedation Score given in your books. When titrating drugs, it's important to understand that elimination may be decreased in many ICU patients because of impaired liver and renal function. The half-life of drugs should also be considered. After changing the rate of infusion, it takes 4.5 half-lives for the plasma concentration to reach a new steady state. For agents with a long half-life, this is a considerable period of time. Therefore, when deepening the level of sedation using these agents, it's preferable to give a small bolus and increase the infusion rate, rather than just increasing the infusion rate. Similarly, when lightening the sedation, it is more appropriate to stop the infusion for a period of time and then restart at a lower rate, rather than just lowering the rate. Whenever you decide to sedate a patient or choose a sedative agent, consider the possibility of adverse effects, including hemodynamic instability, prolonged sedation, withdrawal effects, and specific drug effects, for example, delirium associated with benzodiazepine use. Okay, we're going to pause again. You are asked to design a feeding strategy for patients in the ICU. How, what, when, and how much would you feed them? Think about this for a minute. Enteral feeding is preferable to parenteral feeding as it may prevent the atrophy and possible loss of gut barrier function that occurs with a complete bowel rest, and because it is associated with fewer complications. In general, parenteral feeding is only indicated if enteral feeding is contraindicated or has failed. Feed should include carbohydrates, lipid, protein, vitamins, trace elements, and of course fluid. Caloric requirement can be calculated from basal energy expenditure adjusted for fever and stress. Daily protein requirements can also be estimated. The values shown on the slide are given in your course manual, but in practice, feeding of most patients is much simpler if commercial feeds are being used because they already contain appropriate ratios of calories to protein. In general, feeding should be started as soon as possible, and early feeding, within the first few days, reduces infection and improves wound healing. In patients who are already malnourished, the urgency to start feeding is greater. So how do you go about feeding? Firstly, you have to insert a feeding tube. This is typically a nasogastric tube, although there will be circumstances where a nasoduodenal tube may be useful. After inserting the tube, check the position on the chest X-ray. Other methods of checking are not sufficiently reliable to be used on their own. Having confirmed the position, start with an infusion of up to 30 mL per hour of clear fluid or feed. Aspirate the nasogastric tube every 4 hours. If the aspirate is greater than 200 to 400 mL, stop feeding. Otherwise, return the aspirate to the patient and continue feeding. Gradually increase the volume of feed with the aim of building up to full feeding within 48 hours. Intolerance of feeding may result from poor gastric emptying with resulting high residual gastric volumes. The most important risk is that the patient will aspirate, and the feeding should be stopped if the volumes exceed 200 to 400 mL. Intolerance may also result in abdominal pain, abdominal distension, and diarrhea, but none of the features are specific for feed intolerance. All patients being fed enterally should be nursed in a 30-degree head-up position to reduce the risk of aspiration and nosocomial pneumonia. Diarrhea is common in ICU patients receiving enteral feed, but the diarrhea is not usually due to the feed. It is important to consider alternative causes such as constipation and overflow, drugs, and C. difficile colitis. When the diarrhea is due to feed, it may result from a high osmolality feed or malabsorption. Thromboembolic prophylaxis. DVT is common in ICU patients due to immobility, hypercoagulability, and vessel wall damage, and almost all ICU patients require some form of DVT prophylaxis. For most patients, low molecular weight heparin is the pharmacological prophylaxis of choice, but for medical critically ill patients without specific high-risk features, unfractionated heparin is acceptable. When anticoagulation is contraindicated, mechanical devices such as sequential compression devices should be used. There is no evidence that routine use of sequential compression devices, in addition to pharmacological prophylaxis, reduces the incidence of DVT. Graded compression stockings are relatively cheap and have been used for several decades, but they are probably less effective than sequential compression devices. Stress ulceration. Critically ill patients are at increased risk of stress ulceration because of hypoxic reperfusion injury of the gut and increased gastric acid production. It is important to understand that not all ICU patients are at high risk, and those who are not mechanically ventilated or coagulopathic are not enterally fed and have no major organ failure, probably do not require stress ulcer prophylaxis. Prophylaxis is based on the pathophysiology. Shock and sepsis should be treated early, with specific therapy being aimed at reducing acid production and promoting mucosal protection. However, the benefit of specific pharmacological stress ulcer prophylaxis is controversial. Proton pump inhibitors appear to be more effective than H2 blockers for reducing GI bleeding, but do not alter mortality. It is important to understand that appropriate management of sedation, nutrition, DVT, and stress ulcer prophylaxis are important factors in reducing morbidity and mortality, and careful attention must be paid to these aspects of patient care. Now I want you to write down 3 key learning points from the lecture, 3 things that you think would be important to tell your colleague who did not attend the lecture. I'll give you a minute to do this. Finally, to summarize, target the sedative level to a sedation score, treat pain and monitor for delirium. Early enteral nutrition is optimal, but watch for intolerance. Use pharmacological DVT prevention unless contraindicated.